The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello to all you TMD warriors from beautiful Middle Tennessee, specifically Brentwood, Franklin, Williamson County, Tennessee. I am Tony Urbanic, and we are here for the next installment of TMD Demystified. Today's episode, get right to it, is entitled, TMD is not a psychiatric disease. And this is a topic that is actually very near and dear to my heart because I have been faced with seeing so many patients over my approaching 50-year career treating temporomandibular joint disease that have been placed on multiple types of psychiatric drugs and given psychiatric treatment in an attempt to treat their bruxism. And by treating their bruxism, treating their temporomandibular joint disease, TMJ, TMD. When I was a young doctor, I didn't think much about this issue because I figured the doctors knew about it. When I was a young doctor, I just followed. I was there to learn. I was there to learn from the scholars that I was associated with, or the scholars that I read, or the other clinicians that I listened to. And it actually took many years to realize that on many issues, not all issues, not all parts of science, not all parts of oral and maxillofacial surgery or dentistry, but it took me quite a few years to realize that there are a lot of topics, a lot of issues within the professions, dentistry being included, that the doctors claim they know what's going on, but really don't. And this is certainly one of them. And it is going on today as we speak, as I speak to you on this beautiful Tuesday morning, that applies to many facets in dentistry, but especially our dental schools and teaching programs that are attempting to address the solution and treatment of TMD patients, which is going in the wrong direction. And I speak on that with authority. I claim authority. I do claim authority after 50 years, 36 years of surgical care and 13 years of non-surgical care of the temporomandibular joint, giving up surgery 13 years ago and figuring out what's really going on, what the common denominator and cause is for all the temporomandibular joint symptoms, the disparate symptoms. Please refer to prior episodes regarding this. But not to leave you in a lurch, it's inflammation. Inflammation drives all the symptoms directly. Inflammation directly creates the symptoms. If you remove the inflammation, the chronic inflammation, all of the symptoms subside. And then the question is how and why how does inflammation create the symptoms and how best to decrease inflammation. But getting onto the topic, which is TMD is not a psychiatric disease. It may surprise you, but there is a small but growing number of dental schools, dental institutions, which I will refrain from naming at this time. I'd love to name them, but I'll just leave it unsaid right now, that approach this problem by using what they call a multidisciplinary approach. And one of the primary disciplines that they apply to treating TMD are the disciplines of psychiatry, psychology, and behavioral adjustment. We do not understand the mechanism of bruxism, and the theory behind, if it isn't already obvious to you, or if you haven't learned it or exposed to it, or somebody told you about it, the theory behind bringing in behavioral modification people, psychologists, psychiatrists, and treating TMD is that bruxism, as acknowledged, one of the primary causes of damage to the temporomandibular joint. This is true. If you brux a lot for a long period of time, you will damage your temporomandibular joints, along with the other two causes of damage to the joints, which is direct trauma of various kinds or indirect trauma, like auto accidents and whiplash is an indirect trauma to the temporomandibular joints, which is one of the primary traumatic causes of temporomandibular joint failure and damage. And then functional malocclusions, large COCR discrepancies, mandibular prognathism, mandibular retrognathia, large open bites, those all overload the joint. And that is what all three of those things have in common. What they have in common, whether it be bruxism, direct or indirect trauma, or functional malocclusion, is they overload the joint over a period of time, which then damages the joint, which then creates chronic inflammation. All right, that's the mechanism which is actually happening within a joint. The knee, the elbow, the hip, and the temporomandibular joint all respond to forces which damage the joint. It couldn't be more simple. Orthopedic surgeons know all about this in many ways. We may touch on that in a few minutes. But getting back to our esteemed educational institutions in dentistry, there are a few and growing number which address this problem by bringing in a multidisciplinary group, which would include oral maxillofacial surgeons and reconstructive dentists and people that concentrate on the finer points of occlusion. But in each and every one of these schools, they include psychology, psychologists, psychiatrists, psychologists, and behavioral modification people, along with social workers, in an attempt to decrease bruxism by changing a person's behavior, either through drugs or through other means. And it is obvious to everyone listening that, life does not go on without stresses, without stressors. Everyone has stressors in their life to a great degree, to one degree or another, and most of us to a great degree. And what stresses one person may not stress another person at all. But each one of us on this planet is exposed to multiple stressors throughout their life to a greater or lesser degree. And in a large portion, but not 100% of the population, stress and anxiety and worry converts to bruxism. This is obvious. This is self-evident. This is one of those self-evident truths that can be used self-evidently in the explanation and understanding of temporomandibular joint problems. The issue is we do not understand how anxiety, stress, and worry translate within the brain or wherever. I would assume it's within the brain, most likely within the brain stem, because it is not something that you think about to create bruxism. You're not thinking when you brux, and by the way, bruxism is both clenching and grinding, equally destructive whether you clench without moving the jaw or brux back and forth, both of those motions are equally destructive and overloading the joint and causing problems and destructive to the temporomandibular joint, eventually creating chronic inflammation. But that mechanism that translates thought of one kind or another directly into bruxism, moving, is not understood. And there are some people, doctors, scientists, who claim that they understand it, but we don't. It's the same concept of we don't know what causes migraine headaches, and the scientists agree that they don't know what causes migraine headaches. And tension headaches, the same thing. Anxiety, stress, they just put it into a large basket. It's just a catch-all phrase in a catch-all basket. Tension headaches. Well, we all feel tension, we all feel anxiety, we all have stressors throughout our life. But a large portion of the population, and I estimate, this is an estimate from me, not from scientific articles, but estimate that roughly half the population grinds their teeth, clenches or grinds, bruxes their teeth. Not all of that population creates enough damage to the temporomandibular joint where they begin to have symptoms. But a large part of the population clenches or grinds secondary to stress. And in our universities now, they're bringing in doctors, psychiatrists, psychologists, behavior modification people, social workers who are attempting to decrease the TMD by apparently decreasing stress, either pharmacologically or by talk therapy. But TMD is not a psychiatric disease. TMD is not a psychiatric disease any more than tennis elbow is a psychiatric disease. Discussed that in previous episodes, recent episode. Orthopedic surgeons have known forever meaning for the past 50 or 60 years for sure, that there is what they call joint splinting, where the lateral epicondyle of the elbow, which gets inflamed by too much tennis or too much repetitive motion of the forearm, of the arm, will create inflammation, which will create pain of the forearm, because inflammation sends a signal to the central nervous system. Brainstem modulates, receives that information and sends back a signal through the autonomic nervous system, sympathetic portion, to tighten the muscles so you don't move the elbow. They call that joint splinting. The orthopedic surgeons call it joint splinting. And that is the mechanism, the same mechanism that operates on the temporomandibular joint. And the temporomandibular joint is no different than any other joint in the body in that mechanism. And when that is completely and thoroughly understood, then you understand why the muscles of the mastication in the face and then the neck and then the upper shoulder girdles get the signal to tighten up when the jaw joint gets inflamed, chronically inflamed. Now, to try to treat that mechanism of either the elbow or the temporomandibular joint by psychiatric treatment, psychologic treatment, behavioral modification treatment, is whistling in the dark or barking up the wrong tree, however you want to say it euphemistically. But a lot of money is being spent, a lot of effort is being spent, a lot of multidisciplinary word salad is being directed at using those mechanisms and what is supposed to be our best educational systems and programs in the United States of America and beyond. And I say this not sarcastically. I'm not trying to be sarcastic, and I'm not trying to be overly critical, although it is a criticism. of our educational system when highly trained, highly intelligent doctors, again, I can throw out the names, which I am not inclined to do right now, think that behavior modification, one way or another, is going to stop the symptoms of TMD. We don't even understand the mechanism of clenching and grinding, as I've said. There is no on and off switch. People have no control over it, whether it's clenching during the day or bruxing at night or clenching at night. They have no control over it. I mean, I have so many people come in and once they begin to have positive response by using a device that simply separates the back teeth and unloads the joint, they begin to figure out how to use it, and they use it under times of stress. They say, I figured out I figured out putting this thing in my mouth when I'm in traffic, or putting it in my mouth when I'm sitting on the computer, stressed out about making the buttons work, helps, but it doesn't stop clenching and grinding at all. So, as I have in the past, this title and this episode in this podcast parallels a blog that I write weekly, and it just was published on our website, www.urbanictmj.com. And that blog is also entitled TMD is Not a Psychiatric Disease. And in that two-typed page blog, I very specifically, logically take you through this episode, and I'm referring to that if you want to read on it just a little bit more. But there are so many misunderstandings about bruxism that are just numerous. First of all, as I said, we don't even understand the mechanism for bruxism. Patients regarding bruxism and doctors, dentists galore think that a night guard, that is a piece of acrylic that covers the surfaces of the teeth, either upper or lower, or sometimes both, is going to somehow stop that bruxing activity. Actually, more often than not, it will stimulate bruxing activity. And patients come back constantly with history of 2, 4, 6 or more various night guards that they've been prescribed, used, given over years. And their most common comment is, well, night guards don't work, and they bring in several to show me. Well, that's obvious. If they work, they wouldn't be sitting here asking for help. But still, 2024, half the dentists make a night guard and give it to the patient for TMD. And many of them, without understanding, somehow think that that's going to diminish or decrease or stop their bruxism. Drugs of various kinds do not stop bruxism and diminish bruxism. In fact, certain kinds of drugs increase bruxism, depending on the side effects that have been identified in those drugs. But just about, in my evaluation and experience, just about all types of psychiatric drugs, mood elevators or mood depressors, I have seen prescribed for TMD, with the theory behind it being that if you decrease the mood or increase the mood, that somehow that is going to have an effect on your bruxism. Stressors are stressors, and what's stress to one person may not be stress to another, but everyone feels stress. And drugs are not the answer. It does not control, drugs do not control bruxism. Behavior modification, whether or not you can be effectively changed by behavior modification is not the issue. The issue is changing your mood or your point of view. Will that change bruxism? No, that is not true. People who are bruxers or bruxism. And it's easy to identify a bruxism, by the way. I'll just throw this out very briefly. And I've talked on this before. I think I have another episode on tori and exostosis. But if you, the dentist, and I hope almost everyone viewing these episodes are dentists, when you see palatal tori or you see mandibular tori, bilateral usually, can be unilateral, on the inside of the mandible underneath the tongue to various sizes. But if you see a lump of bone in the palate or on the lingual aspect of the mandible, that is proof that they are a bruxer. And that is because of how the bone is stimulated to be laid down as you press on the tooth laterally, whether it be extension of the palate, creating extension of the palate as you brux, and the mid portion of the palate laying down bone, palatal tori, or the lingual tori, where the anterior premolars, which are only single rooted, will move and stimulate laying down bone, which creates the tori, and lateral exostosis in the areas of the primarily maxillary molars, but you can also see it in the mandibular molars, which is on the labial side of the maxilla and mandible. And those are the more extreme bruxers when you start to see lateral exostosis on the maxilla and the mandible. For the same reason, you stress the tooth as you brux, and then that stresses the bone, and then that is the initiator of laying down slowly excess layers of bone, in which you get exostosis and tori. But when you see tori, when you see exostosis, you know the patient's a bruxer, that's for sure. And very, very few dentists know that as a fact. Getting a little off point here, but getting back to psychiatric care, psychiatric care is no more effective in treating TMD than it is effective in treating tennis elbow. Patients go into drugstores and buy soft things that go in between the teeth, thinking that somehow that's going to stop them from bruxing. It may stop them from damaging their teeth, like a night guard will keep you from damaging, cracking your molars or cracking your incisors. It's a true statement, but it doesn't have anything to do with decreasing chronic inflammation within the temporomandibular joint. So again, if you would like to read about this particular topic on the blog, that can be seen on our website, www.urbanictmj.com. I hope that this episode gives you a little insight into really what's happening in our profession, in our industry. I do not think that this multidisciplinary approach, including psychiatrists, psychologists, and then extends into physical therapists. All of these multidisciplines are only trying to address symptoms. If you really want to take a discipline that will address the common denominator, then I would suggest, and it is on a suggestion, that you bring in cell biologists who can address chronic inflammation. But until a cell biologist and those who study cell biology can come up with a better solution to decrease chronic inflammation within a joint, in this case, the temporomandibular joint, it would also apply to elbows, it would apply to knees. If the cell biologist can come up with a wonderful solution to decrease inflammation, I would be 100% supportive. But until then, I would recommend a device that unloads the posterior teeth, doesn't allow the posterior teeth to touch over a period of time, a specific protocol, because You can't keep the teeth apart forever, or you will get super eruption. That's why there is a protocol, but a device that separates the posterior teeth according to a protocol, which unloads the temporomandibular joint long enough for the inflammation, chronic inflammation within the temporomandibular joint to decrease. And as the temporomandibular joint chronic inflammation decreases, the symptoms diminish, all of the symptoms, and I mean all of the symptoms. Frequent or recurring headaches, earaches, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling, numbness, and various kinds of locking. All of those symptoms are driven by chronic inflammation, and all of those symptoms will diminish and decrease as the chronic inflammation decreases within the temporomandibular joint by unloading the joint, by separating the posterior teeth long enough, carefully enough, so you don't create posterior super eruption, and the problem is solved. Certainly, psychiatric drugs, behavior modification is not the answer. With that being said, I would invite any listeners to learn more about our company and their Urbanic device and protocol by going to our website, or we have currently a planned seminar course in Nashville, Tennessee, and Franklin, Brentwood, Tennessee, specifically Cool Springs Hotel, Courtyard Hotel, which is planned for July 26th. It's an all-day seminar, at which point we will teach you how to use the Urbanic device and protocol effectively in your patient, for your patient's benefit, for your practice benefit, and for the benefit of your community and the benefit of the profession that appears to be going in the wrong direction and not addressing the chronic inflammation of the temporomandibular joint directly. With that being said, I look forward to the next time that I'll be with you, which will be in 1 week, another Tuesday morning. Until then, I am Tony Urbanic, and this is TMD Demystified.